Hello students. This will be an online lecture for eyes. It'll probably be done in a couple of parts. So I'm going to start with the first part here. Looking at the assessment of eyes, we're looking at chapter 14 in your textbook. So some of the external eye anatomy and functions, we have the bony orbital cavity, and the main function of this is just to protect the eye. So that's that circular bone that you can feel going around the eye. The eyelids, they're like two movable shades. They protect the eye from injury. They protect it from light and dust. And then we have something called the palpebral fissure. So the space between your lower eyelid and your upper eyelid, that is your that space between those two, that's the palpebral fissure. So it's an elliptical open space between the eyelids. Comes together, the lids come together when you close your eyes. And then again, when you open them, that space is the palpebral fissure. Oops. All right. One thing that I didn't have in there too is the canthus. Remember the canthus, we have inner canthus and the outer canthus. So those are the corners of the eye. The lacrimal apparatus, that's what helps to provide lubrication and irrigation to the eyes. And then we have the extraocular muscles, which helps you to move your eyes around. The sclera, that's that outer protective white covering of the eyeball. The cornea is very thin and transparent, and we're going to teach you how you're able to see the cornea or to see if there's any bulging or anything with the cornea when you're in lab this week. The choroid, that's the layer around the back of the eyeball. It has a dark pigmentation. It prevents light from reflecting internally, and it also delivers blood to the retina. So it's in the very back of the eyeball. The pupil we know is round, regular. It dilates and constricts according to how much light there is. The lens, it's a biconcave disc. It helps to focus objects. We have the anterior and the posterior chamber. The anterior is behind the cornea, but it's in front of that iris and the lens, while the posterior chamber is behind the iris to the sides of the lens. Both of these contain something called aqueous humor. It's a clear and watery fluid, and it also helps to deliver nutrients and drains those metabolic wastes. Something that's kind of interesting about the aqueous humor is you can get little aqueous threads. Some of that stuff can look like little threads, and sometimes you see little floaters going in front of your eye. No one else can see them, but you can see little squiggles or things, and that's when you have an accumulation of that aqueous humor. The retina is the layer around the back of the eye. It's the visual receptive layer of the eye, so everything focuses back on that retina so that you're able to see. The optic disc, if you look at page 284 in your book, I'm going to turn my page to that. There's a nice picture at the bottom of the page, and you can see that optic disc. It's usually off to one side of the eye, and you can see that there's a lot of blood vessels that go through it as well. The macula, it receives and transduces that light from the center of the visual field. And then we have the fovea centralis, which is where you will have your sharpest and your keenest vision. So you will see your best at the fovea centralis. This is just a little funny that my predecessor put in there. I'll let you read it. All right, we have visual reflexes. We have the pupillary light reflex, which if you have a light shining into the eye, the pupil will constrict. When it gets dark, your pupil will dilate so that you're able to see better. Another reflex we have is something called accommodation, and that's the adaptation of the eye for near vision. So in other words, if you have the person look far away to the wall and then you bring your finger in right up close to them like this, you should see the eyes converge, so they're going to go together, kind of like you were looking cross-eyed, and you should see the pupils constrict. When you look farther away, then the pupils should dilate. So you'll be working and doing this on your lab partners this week to see that. Think of it as a camera lens, and if we want to see things farther away, we're opening the lens up. So the pupil's kind of like the lens, we're opening it up to see farther away, and when we have something closer, we bring that lens in a little bit further, and we don't have to have it open quite so wide. Some developmental considerations that you want to think about. Infants and children, remember that they have very limited eye function at birth. As a matter of fact, they don't really see clear for a couple of weeks or even longer. As newborns, they can see shadows and they can see shapes and light, but they don't see actual faces and things. Peripheral vision is intact in the newborn, so they're able to see off to the sides. Remember, the peripheral is everything to the side. They do not have a macula at this point. And they usually don't have very well-controlled eye movements until they reach about 3 to 4 months old. It's when they reach that 3 to 4 months age, then they're able to focus on an object. Before that, if you hold something in front of them, they really can't focus at that point. And most babies are born farsighted. So the difference between farsighted and nearsighted. Farsighted means you can see farther away better than you can see things close up. Nearsighted, you can see things clearer the closer they are and have more difficulty when they're far away. So, excuse me, most newborns are farsighted, and then they outgrow that. With the aging adult, we have some natural aging changes. Usually starts to occur around age 40. I definitely notice that. I have to kind of hold things out to look at them. We call this presbyopia. Presbyopia. This is something that you're going to want to know. And again, it's changes in the eye that usually start at about age 40. Structural changes, we have facial changes, wrinkling, drooping. If you look at page 307 in your book, it'll talk more about these changes in the eyes that you might see. I just got to get to page 307 here quick. There's a good picture that it's actually called pseudooptosis, and that's on page 307, but you can see the drooping of the eye and the wrinkling around it as well. People, as they get older, have a decreased tear production. We've heard about people having dry eyes, and while this can occur at any age, you for sure will see some decreased tear production after they reach the age of 40, and these people often have very dry eyes. After age 50, being able to see clearly starts to decrease. Of course, it does, as we said, it changes around age 40 as well, but the actual acuity, so how well we can actually see, how clear we can see after age 50, that decreases as well. Some of the diseases that you will recognize are cataracts, glaucoma, and macular degeneration. Cataracts are able to be surgically corrected. We can remove the cataracts, and now when you have cataract surgery, they often put a new lens within the eye, and that helps the person to be able to see better. Glaucoma is a pressure that builds up behind the eye, and it can affect the vision. Macular degeneration, there really is no cure for this. These people gradually lose their eyesight over several years until the point where they're considered legally blind. If you look at page 286, it talks about these conditions. Yes, it's on the bottom, starting in the first column down at the bottom, and it goes back up. There is also one called diabetic retinopathy, and that's one that people who have diabetes, and it says retinopathy, so it's a condition of the retina, and they can have some problems in the back of their eye where that retina is, and it can actually lead to bleeding behind the eye, or it can definitely affect their vision as well. Cultural considerations. When we talk about the spaces, those palpebral fissures between the eyelids, you may see an upward slant in Asian children. If the child is not Asian but they still have this upward slant, what disease do you think they might have? Typically, you'll see that in someone who has Down syndrome. Racial variations in the disease. People can develop that open angle glaucoma 3 to 6 times more in blacks than in any other race. Open angle glaucoma can cause blindness 6 times more frequently in the blacks than in other races. And then I'd like you to read through pages 286 and 287, and it talks about more of those racial variations. So those are some of the abnormal findings that you might see. All right, so just going over to start with some of the subjective data. If some of the difficulties that people might have are things called floaters, we already talked about that. We often see these when someone has myopia. Now, there was 2 types of opias. We had myopia and we had hyperopia. So we talked about nearsighted and farsighted. Myopia is nearsightedness, while hyperopia is farsightedness. And I remember that because when I think of something being mine, like myopia, it's close to me. So myopia is nearsightedness, and hyperopia is farsightedness. So floaters are common when someone has myopia, and they also start to become more common in middle age. You can get them at any time, but that's when we see them most often. And again, these are normal. However, if you start to have a lot of these, or you start to have other problems with the eyes, you want to be very careful and have the person go in to be seen. We have something called a scotoma, which is a blind spot with the area of normal decreased vision. And when it happens really suddenly, one of the diseases we see it with is retinal detachment. So the retina actually detaches from the eyeball, and these people will just have a black spot right in the middle of their eye, and they're not able to see around it. You can also see it with glaucoma and some of those other optic nerve disorders as well. And back to the floaters, these are not normal. This can also be a sign, floaters can be a sign of a detached retina as well. Night blindness, when do we see this? We often see this as we get older. Sometimes people have something called optic atrophy, and atrophy we know means wasting away, so we have some wasting away of the optic muscles and the optic areas, the optic regions. We can also see it with glaucoma, and we can also see night blindness with someone who has a vitamin A deficiency. Pain, when we talk about pain, we're going to ask them about that. Photophobia, that's that sensitivity to bright light, so that can cause some pain. Strabismus, that's where the eyes cross, so we have that deviation in the axis of the eyes, and the eyes actually cross. And then we have diplopia, which is a double vision. Redness and swelling we can certainly see, and we can have some watering and discharge. And then to finish off subjective, we're always going to ask about their history. We already talked about glaucoma being pressure behind the eye and if they wear glasses or contacts.